I have so many friends struggling with infertility and so many friends getting absolutely wildly different information from all of their doctors, like freeze your eggs, don't freeze your eggs. It's okay that you don't get your period. It's a warning sign. And then I read Dr. Natalie Crawford's amazing, amazing book, The Fertility Formula. And I found out that there is a huge underlying cause of infertility that I have never heard anyone talk about. And I was like, I have got to get this woman on the Liz Moody podcast to clear things up. And don't worry, we're definitely going to get into the hidden reason for infertility that nobody is talking about. Dr. Natalie Crawford is a world-renowned fertility doctor. She is a double board certified OBGYN, and she's the author of that book that I mentioned, which is called The Fertility Formula. It is spectacular. You absolutely need to get your hands on it. Today, we're talking about exactly what to do in your 20s, 30s, and 40s for your fertility. And heads up, even if you do not want kids, your fertility is incredibly important for your overall health. Whether you're trying to put yourself in the best possible position for the future that you want, or you're trying to solve a problem, this episode is going to help, and you are going to find information that you will not hear anywhere else. Welcome to the Liz Moody podcast, where we skip past BS, self-help, and confusing misinformation to share actual solutions to your real problems so you can feel as good as possible every single day. What's one thing people should be thinking about when it comes to their fertility in their 20s, their 30s, and their 40s?
One thing I think we miss when we're in our 20s is that our period is a vital sign. Learning to track your cycle and know what's normal, know what's a baseline for yourself can really be a huge advantage later on. It allows us to intervene sooner to say, oh, well, if my cycles are off, I need to get that checked out before I want to get pregnant, or learn how to track your cycle. When did you learn how to track your cycle, Liz?
I don't even know if I technically know because I use an app to do it. I use Natural Cycles.
Yeah, and I love that product because it's checking your body temp in addition to just the days. But so many women, I was one too. I was on birth control for an extended amount of time, came off, and then had no idea when I was really ovulating, except for what the calendar said I should be ovulating, which isn't really tracking your cycle.
Well, and it's also interesting because once I started to track, I started to see very clear signs of when I was ovulating. And now I'm like I can feel it happening.
100%. And if you use an app alone, which uses the calendar method, which is different than Natural Cycles because they use your temperature. But an app alone that's just using the calendar, I put cycle day 1 into this cycle app and it tells me when my fertile window is. That is only accurately predicting ovulation 21% of the time. So most of the time it's actually getting it wrong. And that's scary information if that's all.
Why?
The calendar method is going to assume that all women have a set luteal phase. Women have a lot of different lengths of the luteal phase, and not everybody's set at 14 days. So better ways are what we call fertility awareness methods. And these are really trying to look at the signs your body's giving me about when you ovulate. So basal body temperature, once progesterone is made, your core body temperature is going to rise by at least 0.4 degrees Fahrenheit. That's how Natural Cycles works. That's one method. There's also cervical mucus, which once you learn how to check your cervical mucus, it's actually quite easy.
What do you mean by check it? Because I feel like
you just know.
I notice it.
Yeah.
It feels very noticeable.
It is really noticeable. Here's what I say for checking it. So cervical mucus is a protection for your uterus. It doesn't want any bacteria or anything bad to get in. And so the cervical mucus, when you cannot get pregnant, is more of a barrier. And then as estrogen rises, it changes the elasticity and the stretchiness and the water component of cervical mucus so that sperm can penetrate. So it'll go from having no cervical secretions to then getting creamier and white as the estrogen starts to rise. And then the type 4, or your peak cervical mucus, is sticky, stretchy like an egg white. Well, that can sometimes fall in the toilet. Just take toilet paper, wipe first before you go to the bathroom, and then look at the toilet paper to evaluate what is there. And if it's like an egg white, then that counts as your type 4 cervical mucus.
So when you say that you wish people in their 20s were tracking their cycles in a way that would give them this important information about their fertility, you want them to be checking their cervical mucus? You want them to be counting the days between their periods? What specifically should they be doing? And especially, I think in this day and age, people are more hesitant about apps with the data and the privacy and all of that kind of stuff.
I think those are fair concerns as far as privacy goes. At the end of the day, we have to be our own advocate. So I say, number one, you do want to know the cadence of which your cycles are coming, meaning, is it every 28, 29 days? Is it 26 days 1 month, 35 the next month? Your cycle should be regular and predictable, meaning if I put a calendar in front of you, you could put your finger on the day your next period is going to come and be within 1 or 2 days of accuracy.
But it doesn't matter whether it's 35 days or...
Yeah, everybody's a little bit different. So it could be anywhere from 25 to 35 days, but for you, it should be within the same little grouping of days. I do want you to know when you're ovulating specifically, learn how to track ovulation. So this can be basal body temp, old school thermometer, newer thermometer, wearables, those all work.
And it'll rise when you ovulate.
Rises and stays high for at least 3 days after you ovulate. Number 2 is going to be the cervical mucus, like we just talked about. The last day of that type 4 cervical mucus is considered your ovulation day. And then number 3 is going to be urinary hormone measurements. So there's many different options to actually check. Ovulation predictor kits is one thing we call them. They're a urinary-based kit, like a pregnancy test.
I'm going to get in the head of somebody in their 20s, of myself in my 20s. And I'm like, this feels like a lot of work that you're asking me to do just to I just want a green flag that I can not worry about this for a while. Is there just a simple test that I could take if I'm in my 20s and I just want to be you have permission to not stress about this for a while?
I don't know that we'll ever give you 100% permission to never stress about it. Some of the hardest cases that I see are women who are specifically on contraception and they're in their 20s, and I love that contraception gives people the opportunity. I relied on it for a long time. Chase your dreams, not worry about getting pregnant. It's extremely important. But you do lose all of this cycle tracking awareness while you're on contraception. And so women who come in, stop the pill, pull their IUD, and find out that they are in ovarian failure and have no eggs left, I have diagnosed women in their 20s in that position. And that's scary. You can't go backwards.
And what signs would there have been if they weren't on contraception?
Their periods would have changed. They would have started to have cycles that were closer together. They would have then started to have irregular cycles. They would have had more low estrogen days, and they would have gotten an evaluation when they really felt bad, for lack of a better word, when they were in perimenopause, before they were in true ovarian failure.
Yeah.
But that was masked. So I do think you don't have to be off contraception forever. I was on the birth control pill for more than 10 years. I wish at some point in my 20s, I would have come off it for a few months, learned to track my cycles, knew what was happening. If everything was normal, then I could feel more confident going back on my contraception, but knowing that things were okay and at least having the tools and the skills to track later when I wanted to get pregnant. The second part of that question is there is a blood test called AMH. It's not perfect. It has limitations, but we should talk about it. AMH stands for anti-Mullerian hormone. AMH is made from the cells that surround all the follicles. So if you have more eggs in your vault, one really important concept is that more come out every month. So in general, when you are younger, you're going to have more eggs available to you. And as the vault gets emptier, fewer eggs come out every month. This means that your AMH would be lower if you have fewer eggs and higher if you have more. AMH can give us some insight that at least we're not running out of eggs. And more so than that, if it is low, so in those patients I previously talked about, had they had an AMH done, even though they were on the pill or had the IUD in place, they could have detected that it was low and then started an evaluation for one of the biggest questions I have, which is, why is it low? I should add that this is nuanced. So the American College of OBGYN recommends not checking an AMH unless you have infertility. I actually disagree with this completely. Their argument is that it's not proven to cause infertility and that it can cause undue stress in women. Well, it's true. If you have, in principle, 5 eggs outside your vault and 20 eggs outside your vault, if I have 2 different people, and we're both ovulating and we're both the same age and we don't have any other medical problems, we do have the same odds of getting pregnant per month. However, why is it low? Because a lot of the things that cause a low AMH do in fact contribute to infertility. Things like autoimmune disease or endometriosis. And we do start to see cycle abnormalities where it becomes harder to ovulate. So I think it's a simplistic view to say AMH doesn't impact natural fertility at all and that we shouldn't check it in women who don't have infertility. I might have done something different had I known I had a low egg count at a younger age. Many women might feel that way, where maybe you say, I'm not ready to get pregnant now, but at this day of age, we could freeze our eggs. So I think that checking an AMH for a woman in her 20s who says, I want kids one day, but not yet, is an important step.
I want to touch on birth control, and then we're going to get into the 30s, I promise. But you've mentioned birth control a few times. Is there any indication that any types of birth control would impact our fertility once we go off it? Obviously, it's going to impact our fertility when we're on it.
Yes and no. So in general, we have to remember the definition of infertility, which is what studies are looking at, is not getting pregnant at 1 year. So 12 months of trying to conceive without getting pregnant. So with the exception of the Depo-Provera birth control shot, so Depo-Provera is the injectable progesterone, you would get it every 3 months. It prevents ovulation in almost everybody to the extent that it can be a birth control every 3 months. But one single injection can prevent ovulation for 18 months. So that we want to make sure you're stopping Depo-Provera at least 2 years before you want to get pregnant. So you really have to be thinking about that one. I'll also say that other forms of contraception, when we've evaluated them, there's no increased rate of infertility, meaning by 12 months, no difference in people who used the birth control pill or didn't, or people who had an IUD or those who didn't. That being said, there is some month-to-month variances, especially the longer you've used contraception, and the progesterone IUD is one of the more specific ones. It is progesterone localized to the uterine environment. It's a wonderful long-acting contraception. Put it in and don't think about it. Many women will say they have really light periods or no period. But what that's doing is actually suppressing the endometrium from growing. And it can actually change gene receptivity inside the uterus for up to 12 months. So I usually recommend people at minimum get a progesterone IUD removed 6 months before they want to get pregnant, give you time to get that lining to build back up. Of course, if your period is a vital sign and you have no period, we don't even know if you're ovulating, but also so that we don't have that longer term side effect of some of that chronic progesterone exposure that can happen inside the endometrium. So even though they don't cause infertility, I think there's a little more nuance than just pull your IUD and try to get pregnant the next day. If we are sitting at the table saying, I want the easiest chance getting pregnant or the highest odds of conceiving once I start trying. I do, though, recommend that people stop the pill 3 months before they want to get pregnant. It's not to detox it, but it's because we just explained how understanding your cycle is a vital sign, how important it is to track it, and you're not tracking it when you're on the pill. So I'd rather you say, okay, if I want to get pregnant this summer, let me come off the pill. We can use condoms, do something else, but let me track my cycle, because if it's irregular, if my luteal phase is super short, if I'm having a lot of breakthrough bleeding, if I don't have a period at all, well, now I don't need to try any amount of time. I have a problem. I need to go to the doctor and get this evaluated now. So it's really allowing ourselves to make the most of those conception attempts by having more awareness of what's happening in our body.
What about the people who are like, I'm off the pill and my period still has not come back?
It should come back. Truly, you should have a bleed. If you are ovulatory, you should have your next cycle truly within 4 or 5 weeks from the last time you took the pill. If it is not happening, you're not ovulating. Now, what happened, especially in our generation, is many women got put on the pill for a variety of problems in their teen years or college years. I have cramps or heavy bleeding or my cycle's irregular. And instead of any discussion or any evaluation, what was the solution?
Give you the pill.
Here's your pill. And it's not that that was necessarily the wrong treatment, but the approach was absolutely wrong, meaning we should have had a discussion about what was going on. Many women in their teen years would have really irregular cycles. Their bleeding would be heavy. And their doctor might know or have a high suspicion, oh, Liz has PCOS. But instead of telling you that, talking through what PCOS could mean for your lifetime, and maybe saying the best thing right now or a great option could be the birth control pill, but we're going to want to test these different things, or you're going to want to learn about this over time because this is not going to go away. You were never told anything. You're giving a pack of pills. You think everything's fine. Now you stop them and your period doesn't come. And there's this narrative online that the birth control pill causes something called post-birth control pill syndrome. And reality is it doesn't do that. It's just now your body has to do the job. And if you have some miscommunication between your brain and your ovaries, the pill's going to mask that. And when the pill is gone, we can see what's truth. And it does feel like you're behind the game. If you're on contraception until 35, now you're ready to get pregnant. Now you stop the pill. Now your periods are irregular. And you've never heard any of this before. That's highly frustrating.
Which is why one of your pieces of advice for people in their 20s is go off for just like a short amount of time and get the information.
Just get the information.
Because then if you find out, okay, I have PCOS, you could begin to work with your doctor on that.
Well, now you have 10 years to learn about what that means. How should you eat for PCOS? How might this impact your ability to get pregnant? And you might frame your future decisions differently because you now have more information about your body.
Yeah. Okay, we're going to get into so much more for people in their 20s. So listeners who are like, wait, I have more questions. We're going to get into them, I promise. But what is one thing that women in their 30s should know if they're thinking about their fertility?
There's scary stats about your fertility, but I do think that they're important to bring to light. You guys like, you got stats on your cards right there.
I do. Do you want me to? I mean, this is the stat that made my blood run cold. You wrote this in your book. In order to have a 95% chance of having kids, you should start trying to get pregnant at 32 for 1 kid, 27 for 2 kids, and 23 for 3 kids.
These are scary stats. To clarify them, this means if you want to have over a 90% chance of having that size family without needing IVF, or intervention, right? So if you say, I'm okay freezing my eggs or doing IVF, the data is a little bit different. But if you said, and there's people who say this, maybe I don't believe in IVF, I don't want to do that, but I really want to have 2 kids.
Or it's so expensive, which I also think
True.
is like something that's missing from this conversation often is I have friends who have spent over $100,000 because they want to have children.
Yeah, and it's not always something that everybody can do.
No,
right?
it's not something that many people can do. I know friends who are going into massive amounts of debt because this is a dream of theirs.
Yeah, I mean, there's states that offer, fertility mandated insurance, but, I don't live in one of those. Yeah. I'm in Texas. So my patients, the vast majority of their insurance covers nothing, and they are pulling out loans. And one of the things that they say frequently is, had I known this earlier, I might have done something different. So it's not a scare tactic, but it is to say, we really want to have 2 kids, lifelong dream. We can't or don't want to do IVF. Age 27 is the average age of which we need to start trying for those kids.
For 2 kids. 23, though, for 3 kids. Natalie.
I was nowhere near ready. I was nowhere near ready. But the other side of this discussion is, let's say you're not that person. You and I are not those people, So if you are not that, and those numbers do feel scary, what does that mean? What I want women to understand is your eggs are inside your body your entire life. They absorb the wear and tear of the world around you. And that's what happens inside our ovary as well when it comes to chronic inflammation. So aging and ovarian aging is more than just the numerical age that you have. That's a piece of the puzzle. But the metabolic and cellular health of your eggs matters a ton. Your eggs have the mitochondria that's getting passed on to the embryo. The egg alone controls fertilization, controls the first 3 days of embryo growth. The health of that egg from a metabolic standpoint determines your ability to get pregnant as well. So as we get older, yes, eggs have been in our body absorbing some wear and tear, but in general, across the population, we also get less metabolically healthy as we age also, right? We have more insulin resistance. We tend to get more overweight. We're not as healthy as we were when we were younger. So for many people, their eggs take a double hit with age. That's a modifiable factor right there. So you can't change your number on the clock. You can't rewind time and do something different, or you're in your 20s or your early 30s and you are nowhere near ready. Well, then it's even more important that you take the proactive steps that you can. So part of this is the testing, the AMH and the understanding your cycle. But the other part of it is, well, what causes chronic inflammation and how do I start to decrease that? Because I want to make sure that I have the most metabolically healthy eggs that I can.
You wrote in your book that chronic inflammation is the top cause of infertility that nobody is talking about. Can you explain that?
Inflammation is really important in reproduction. So I think we have to understand the difference in acute and chronic inflammation. Acute inflammation is a normal body function. You cut your hand, your inflammatory system gets activated, the immune system sends out cells, it's going to get inflamed and heal the cut. That's normal. And acute inflammation is important in the follicle when it ruptures to allow the egg to come out and to reform, and even in the implantation process. So we don't want to act like all inflammation is bad. But chronic inflammation is the constant activation of your immune system. And this turns into a stressful system inside your body, essentially a toxic environment. And the reality is we live in a world that is full of inflammation. We are constantly exposed and doing things, whether we realize it or not, that are contributing to what I call the inflammatory burden. How much inflammation you are exposing your body to every single day. The body is not meant to be constantly inflamed. And when it is, your system starts shifting to battle this inflammation. There's very distinct hormone change that starts happening. The brain can't interpret hormone signals correctly. It can't send out hormone signals correctly. Inflammation changes the ovarian response and how it responds to hormones, how it makes hormones, how your mitochondria function. damages the eggs directly. And the same thing happens in men when it comes to sperm as well.
Oh, we're going to talk so
It's
much about
we'll
sperm.
talk about them, but I don't want them to
Yeah.
think that they're getting off easy here. In fact, it's harder. These are not mystery things. And I really want to stress to people, we shouldn't be starting by talking about taking anti-inflammatory medication or doing crazy treatments. The reality is most of the things that cause inflammation in our body are foundational lifestyle principles, the foods that we eat, the chemicals that we're exposed to, how much sleep we get, how stressed we are, and how we move our body. This is what can improve or harm when it comes to that inflammatory burden. I will tell you, I had infertility myself and I had pregnancy loss. And I had all the tests done, was told just bad luck. I think when you go through something in a health journey, no matter what it is, one of the first questions you probably ask when you're receiving this bad news is, well, what can I do?
Mm-hmm.
And I was told, just keep trying. And I felt like there's no way that was the only piece. And I said, well, what about, are there foods that I should eat? Are there different things I should do? Is it okay that I'm running? What about all these things? None of that matters. That's what I was told by my own physicians. Yet when I was in fellowship around the same time, I just didn't believe that some people just have awesome luck and some people have terrible luck, and that these things had zero impact on our outcome at all. And so I did all of my research in fellowship looking at natural fertility and looking at some of these factors. Why do some people have an easier time getting pregnant than others? And looking at the luteal phase and vitamin D and environmental toxins and ovarian reserve and omega-3 fatty acids, and really seeing that word inflammation throughout all of this medical literature, even though as a physician at that point, inflammation was really only something we talked about on the disease pathway. We talked about endometriosis causing inflammation and that is harmful, but not that before you ever get to disease, inflammation is brewing and changing your body on the inside. And I think that is what a lot of women from an earlier age, if we think about, our eggs are inside our body our whole life. So starting to pay attention to some of these factors earlier is going to make your reproductive journey a lot easier.
This is where we get into some of the trickier parts of the fertility conversation in my mind, because I do feel like I want to empower every single person listening to or watching this episode. And I am just, my heart goes out to anybody listening who is dealing with infertility and is like, oh, so it's my fault. Like in my busy life, I didn't eat the right food. Like, look at what I'm trying to accomplish every day. I'm too stressed. What am I supposed to do about that? You know what I mean? So how do we empower people without blaming them for their current state?
There's no one thing that's going to cause or cure infertility. And I think that's a really important concept. And as somebody who went through this myself, I don't take blame. What I hate is that I didn't know. And so not being armed with the information to start making change when you can, that's really the most hurtful narrative. And this is why so many physicians for probably so long have failed to discuss some of these factors, because it can, maybe it's not received well, or it's so nuanced. We're all really individual N of one experiments. So a lot of this is learning to understand your own body. So there's probably no one thing you did that can cause your infertility, but it's the sum of all of these decisions that you make that can make it easier or can make it harder. So if we sit here from the place and we say, I want my body to function the best that it can, I want to feel my best. So knowledge is empowering, because then you can make the choice. And you might choose different in this one meal, or you might choose different when it comes to your sleep one night, or you might choose how you mitigate your stress response the next time, because at least you have that power to know what's happening in your body. It's not, oh, I need to go on this diet. It's, oh, I'm making change because this is going to improve my health, my fertility, but also my longevity. Fertility is really connected to your overall health later.
Yeah, I thought that was really interesting, is that you talk about, even if we don't necessarily want to have children, the fact that infertility rates are going up is something we should all be worried about. Can you talk about that?
Absolutely. Well, infertility rates are rising. When I first started in this field, we used to say 1 out of 8 couples had infertility. And presently in the United States, if you're trying for the first time, it's 1 out of 5. So huge increase in the rate of infertility. In the same timeline, we're seeing miscarriage rates go up. We're seeing the rates of low ovarian reserve increase. Sperm counts are dropping. Testosterone levels are dropping in men. But to your point, the scariest stat in my whole book to me is the fact that your fertility is a health marker, meaning if you have infertility, you have about an 80% higher chance of having a stroke or a cardiovascular event like a heart attack or having metabolic disease later in life. That's wild and scary. And as somebody who had infertility, I hate that data. That's why it's so important to think about your fertility, not just as a disease, which it is, but also as a symptom of something happening in your body. For many women, you're relatively healthy. For many people with infertility, they really don't have a health problem until this. They've gone to their annual exams. Now suddenly they have infertility. And this is the first time they're navigating something different or wrong in their health. And this is your body's red flag that there might be something at a cellular or metabolic level. Because if we step back, chronic inflammation is that connecting dot that's also increasing the risk for heart attack, stroke, metabolic disease, cancer, earlier death. And so if we can stop that sooner, regardless if you want to have children or not, you're going to have a better life.
And just to address kind of like the thought I immediately had, which is people are having kids older and older and older.
Yeah.
Is that the reason that infertility rates are going up, or an absence of age data?
An absence in age. Definitely women starting to have families later contributes to the global picture of people having smaller family size. But even when we control for age, it's harder to get pregnant. We know that if you're also waiting to get pregnant, it's even more important that you know this information well before you're at the place where you want to get pregnant. I hate the current narrative. Infertility is defined as the failure. And right now, the medical recommendation is that we don't even check anything that can impact your fertility until you have failed to get pregnant for 12 months. That's when you qualify for fertility testing. So we make women fail by definition before they can come in, see a fertility doctor, find out if their tubes are open, if their uterus is normal, get their blood work drawn, get a semen analysis. And I don't think that makes sense in the current world where infertility rates are rising and women are waiting later. If you want to have a kid one day, this is a life goal for you. We should approach it like we do other life goals, which is never, we'll just deal with that when the time is here, right?
Yeah. So how can we do that? Like, can we go to the doctor and ask for these tests years in advance? Will our insurance cover that?
So insurance doesn't always cover that. So I think that is definitely hard because it doesn't even cover infertility for a lot of people when they do meet the definition. So let's not always make decisions for an insurance policy that may or may not kick in, but definitely you should understand the parameters for where you are. We already talked about the AMH test. If you want to have kids one day as a life goal, you should get that done in your 20s. We don't have great data on checking it serially, but I think another good time to check it is your early 30s. If we look at egg freezing data, the highest ROI for freezing your eggs is if we freeze them between age 31 to 33. So if you want to have kids one day, you're 31 to 33 and you're not ready now, that's a great time where you should get a high number of eggs. Quality should still be good, meaning for one single cycle, good return on that investment.
Why wouldn't that be in your 20s?
This is cost-effective analysis is where this data comes from.
That's part of the
That's
ROI.
Part of the ROI kind of decision tree here, saying that, well, a woman in her 20s may start trying to get pregnant on her own,
right?
And may not.
I'm just
ever
curious,
need
like
this.
in the future, ostensibly, like might there be a world where every woman freezes their eggs at 18 just
Liz,
to like have the option?
I say all the time that you should freeze your eggs the moment you're asking the question. It's expensive, and that's why most people don't do it in their 20s. Yeah. Dak Shepard just came out and said he's going to pay for his daughter to freeze her eggs when she gets out of college or when she's 18 or something.
Yeah.
That's incredible. I will do that for my daughter.
And the idea is you'll get way more eggs when
you'll
you're
likely
18.
Get more eggs and better quality. We'll just say 18 through 30. Your 20s are your most reproductively fertile years, even if you are less metabolically healthy, because the eggs just haven't been there as long.
Yeah, we're going to get into more egg freezing later. But yeah, going back to this.
If you are with a partner and you want to have children with that partner, even if you don't want to right now, I love seeing these people for fertility testing. Are your tubes open? How is his sperm? Get hormone tests done. I see couples every week make a different decision than they would sit at this table and say they would make. Because we can make a lot of assumptions about what we would do. But when we're put in that position, we might do something different. And, sperm counts, as we'll talk about, that is a modifiable factor sometime. But if you find out your fallopian tubes are blocked, for example, we can't go unblock them. So if your tubes are blocked and you're 30 and you're with your life partner, but you're starting a business and chasing big dreams, amazing. But I can tell you at age 30, you're going to need IVF to have kids. Why would you not freeze your eggs or embryos or at least start saving for it? There's no way with that knowledge you would just try to get pregnant for 12 months before you come see us. Everybody should get testing if there's a problem. Irregular cycles, bleeding through your clothes, very painful periods, bleeding in between your cycle, intramenstrual bleeding, known problem that will cause infertility, notably PCOS and endometriosis. If you carry those diagnoses from when you're younger, you don't need to try for any amount of time. You should go to the doctor and get testing first. Same for men. If we have low libido, difficulty with erection, ejaculation, or if we've been taking testosterone, go get an evaluation right away. There's really no reason why a man should not get a semen analysis. It is so easy. There are mail-in options.
Arguably fun.
I mean, much easier than what women have to go through.
I know. When we did my embryo freezing, it was just like not lost on me that like I'm going under anesthesia and getting surgery, and Zach's going into a room and they're like, here's the computer. You can use this if you want.
Here's the coffee bar. Yeah. Like hang out here, play on your phone. It's wild.
Yeah. They're like, enjoy your porn. And I'm like getting a surgery. Should we be doing some sort of testing to see if inflammation issues are at the root of our infertility? Or are you just like, universally, 20s, 30s, 40s, even if fertility is on your mind, inflammation is something you should be trying to address?
The best approach for inflammation is proactive is always better, meaning preventing inflammation from coming is always going to be better than waiting for disease to exist. So setting a good foundation for how you live your life the majority of the days is going to allow you flexibility for when life happens and you can't be that perfect, low inflammatory life. So cultivating those really good habits from a younger age are going to be key no matter what. When patients have infertility, I think it's different, meaning if you're having recurrent pregnancy loss or cycle abnormalities or infertility, and we're trying to figure out what's going on, I think there should be more focus on checking for inflammation, checking for autoimmune disease.
What do you think are the 3 biggest needle movers in terms of reducing chronic inflammation?
Sleep, building muscle, and the foods that we eat.
Okay, be more specific. Sleep, What are we going for?
This is the easiest way to describe sleep is when your body is going to heal inflammation. Your inflammatory descent goes and your cells heal up and get ready for the next day. So that takes a set amount of time to get that job done. So we need at least 7 to 9 hours of sleep per night. Women, most of the time, need at least 7.5. But a third of US adults sleep less than 6 hours a night. So we're not anywhere close to hitting that mark for a variety of reasons. Phones in our bed, light, TV.
Yeah, I'm curious, like, how much sleep do you get? You're on book tour, you are a doctor running a clinic, you have 2 children. Like, how much sleep are you getting?
You know, it's so funny because I used to be that person who was like, I only need 5 hours of sleep, right? I kind of like wore that like a badge on my shoulder that I didn't need it. I need 7.5 to 8 hours of sleep, or I feel like a hungover person. I don't drink anymore, but I notably am slower, not as sharp, and do not function as well when I get less than that.
And do you have time to get that much sleep?
Most of the time I do. I do have kids. I have a husband. And I'll be honest, like there are times where I have an early day and I'll go to bed and he'll stay up and do other things. You know, it's a teamwork approach. But again, if I do that most of the days, then days like today where I got up at 4 to get on a plane to get here, that doesn't hit me as hard because I'm not already running on fumes. I'm not already inflamed. I sleep in an eye mask. We have a sound machine. You know, we sleep with it cooler in the room. I like a weighted blanket, put the phone away from where we are. You know, we don't watch TV in the bedroom anymore. All these little things that we think about that how many people just sit in bed and doom scroll? I mean, I used to do that like forever.
And I think you're making the connection, like you might not think this is associated with fertility, but it actually is.
And to get more specific when it comes to sleep and fertility, your gonadotropins, so those are FSH and LH, which we talked about earlier when it comes to your menstrual cycle. Those are the hormones that control estrogen, progesterone production. They are released from the brain in the early morning hours after you've had a certain amount of sleep. So if you're not sleeping enough, you're already shunting your brain's ability to send out those hormones appropriately. From fertility studies, for every hour less of sleep you get, in IVF studies, 1.5 fewer eggs retrieved. So very distinct, less sleep, less eggs. We see that sleep variability. So not just amount of sleep, but having a consistent sleep schedule with circadian rhythm improves your time to pregnancy. People with more variable sleep patterns takes them longer to get pregnant.
That's so interesting because I say constantly, my whole community, we go on circ walks in the morning to set our circadian rhythm. And what I say is that it impacts 99% of the cells in your body.
Yeah.
But I've never made the connection that it would impact pregnancy or fertility.
It does.
Ugh.
And it impacts sperm and testosterone production. So men who don't sleep enough also have lower sperm counts, testosterone production. This is what I say is the number one thing most of my patients are not doing as good as they can and kind of brushing off a little bit.
Okay, talk to me about building muscle.
When it comes to building muscle, I think we do have to enter into this insulin resistance discussion because this is part of how it helps the most. So if we want to think about hormones, insulin is a hormone made from your pancreas. Many things cause what's known as insulin resistance. And the way I want to think about this is from some of the foods that we eat, especially those processed foods, from frequent eating, not getting enough sleep, we have higher glucose levels inside our body. This means the pancreas is going to send out more insulin. Let's imagine insulin is a salesman coming to your door. So knock, knock, open the door, let glucose inside. Well, what are you going to do if a salesman comes every single day and knocks on the door?
I'm going to lock the door.
You're going to not answer.
Yeah.
I mean, that's what your cells start doing too. They're like, I am so sick of seeing you, insulin. And they stop answering. So then it takes more insulin to get glucose in. So now insulin's banging on the door. So you finally open it to let glucose in. Now, the problem here is high insulin. Insulin's a growth factor. Actually causes you to distribute that visceral fat that's highly inflammatory, that actually, is going to change how your body makes hormones in a different way. Your cells are not getting the nutrients they need because glucose isn't getting in the cell. So you get into this really nasty cycle that's highly inflammatory. Well, we can break this cycle from a lot of different ways. Sleep, not eating late at night, some of the foods you eat, not having quite as high of what we call a glycemic burden. But muscle, your skeletal muscle specifically, has what's called GLUT4, which is a transporter that is like giving glucose the key to the cell. And I no longer need insulin to get it in. So if you build some muscle, glucose levels are getting down, therefore less insulin being made, and you're resetting this insulin resistance process. One of the best ways to decrease insulin resistance is by building and using that skeletal muscle. Picking up weights 3 times a week should be a part of what you do before you want to get pregnant. When you're trying to get pregnant, when you are pregnant, you should be lifting weights to build and use that skeletal muscle.
What are your thoughts on the scientific merits of something like cycle syncing your workouts to your different points of your cycle?
What I love about cycle syncing is that you have to track your cycle to cycle sync. Now we have more cycle awareness than ever. So I'm a really big fan of that. What cycle syncing is the idea that you do more intense exercise in the follicular phase versus in the luteal phase, you do, we'll say, easier things. Number one, I think strength training and resistance training 3 times a week, no matter what phase of your cycle is the key here. Now, understanding cycle syncing can be helpful because most muscle building plans are made by men and they progressively are going to load you every week or every other week. And it can be extremely frustrating for a woman. You're doing great week 1, great week 2, you're okay week 3, and week 4, you crump out. You're like, why I can't do what the plan says, and it's very discouraging. But if you understand, elite athletes don't usually perform their best in the luteal phase. You're going to have a harder recovery, that maybe that's not the time for progressive loading or for trying to go for more reps. Really learning to listen to your body and give yourself grace. To me, that's a part of cycle syncing. I think that's beautiful because you can say, okay, I can't really add on, but I'm going to try the same thing next week and I'll be in my follicular phase and maybe I'll be better. There's no one-size-fits-all approach, but what should be one-size-fits-all is picking up weights 3 times a week, no matter the phase of your cycle you're in.
Are there any types of workouts that have a negative impact on our fertility?
There are. So vigorous activity for 60 minutes or more has been associated with lower pregnancy rates in the majority of people. And HIIT workouts, we'll say, is going to be on the fence. So sometimes high intensity interval training, especially if you're doing it for a lengthy amount of time, like 60 minutes, we can say that is too stressful for your body for the majority of people. Shorter high intensity interval training, maybe not, depending on where you are. Highly effective for weight loss, right? Can be really great for cardiac health.
I do it for my VO2 max.
And great for longevity.
Wanna, hold on to that.
Yep.
So how do I approach that?
How many times a week do you do it?
I do it 1 to 2 times a week.
So what I usually say for fertility is once a week.
Okay.
Doing that is giving your body enough time to kind of recover from it versus the constantly challenging. We do know that runners, over 50% of them have a luteal phase defect, meaning their luteal phase tends to be shorter.
So if a runner is listening to this, should they stop running?
It depends on where you are. So, if you're doing IVF I always say stakes are high in IVF, risk for error low. So I'm going to make you stop running. In general, when you do fertility treatments, the rules are a little bit different. If you're trying naturally and you're a runner, we titrate to cycle. So if your luteal phase is less than 11 days, you're running too much. You need to cut back. Most average running around the lake runners who are running a few miles a few times a week, they're fine. We're really talking about our everyday runners. You're training for a marathon, you're doing extensive long runs on the weekend. That's where we tend to see it an issue.
So if you're having fertility challenges and you're training for a marathon, that might be something you'd want to reconsider.
It is. And something I tell my patients is we might want to pick a goal at this life moment that we're trying to focus on because these two might be in conflict.
Okay. And then the last one is the foods that we eat.
Ooh, the biggest one, right?
Yeah.
So the foods that we eat absolutely impact our fertility on so many different levels. Inflammatory foods have a double hit on us because they directly damage the gut and they then also damage our gut microbiome and they can cause insulin resistance. There's multiple different ways where they impact our gut health and our hormonal health. When it comes to the gut microbiome, estrogen is metabolized inside the gut. And so a lot of people have never heard of the estroblome, which is the microbes in the gut that are really important in the estrogen metabolism process. So directly, hormone levels are going to be dependent on how healthy your gut microbiome is. The gut microbiome lives on fiber. Fiber is the food for your gut. So if you eat a fiber-rich diet, typically we're thinking lots of fruits and vegetables, which have other great nutrients and antioxidants, they also are the highest source of fiber, going to be very helpful. One thing that we see a lot, especially in today's protein-focused world, and I don't want to say that protein is bad, but animal protein doesn't have any fiber in it. So if you are on a carnivore diet and you're just eating animal protein, you're not eating any fruits and vegetables, we are seeing a shift in your gut microbiome, not in a positive way because they're not getting the nutrients that they need.
Which impacts your estrogen.
Exactly. And then also impacts your levels of inflammation inside your body because your gut microbiome is one of those first lines of defense there. On a very simplistic, just looking at the gut layer, we need fiber. We need to avoid ultra-processed foods that are highly inflammatory. And we should be limiting certain foods that are not providing any nutrients to our gut microbiome. An anti-inflammatory diet is one that's high in whole foods. Fruits and vegetables are the mainstay. The recommendation is 2 servings of fruits and vegetables at every meal, which many people get much less than that. But that's what's associated with the shortest time to pregnancy and improved pregnancy outcomes with IVF.
Is that true for men and for women?
It is. It's true for both. And it's even true just looking at fruit. So I think sometimes fruit gets a bad reputation. Just increasing your fruit servings is going to be helpful as well. That's really what we should be centering a plate around is those fruits and vegetables. Protein's important, but what we know from fertility-based studies is that replacing animal-based protein with plant-based protein sources, so think your legumes, beans, lentils, tofu, that improves ovulation and improves pregnancy outcomes. Nutrition studies are hard. And I think this is a really nuanced topic that people need to understand because you cannot control everything. And people who tend to eat a less good diet also tend to have less good other behaviors that are often not controlled for. But we know when more red meat is consumed, we have poor embryo development in IVF. We have worse staging of endometriosis, and we see poor sperm parameters. So we don't want to sit here and act like the steak is the end-all be-all on the side of the new food pyramid is really what's representative for your fertility. Healthy protein-based sources are important. When it comes to the meat discussion, even poultry is negatively associated with fertility outcomes. So meat servings should be replaced with plant-based servings and at least some of your meals, some of the days. Eggs look neutral to good, meaning they don't cause inflammation. Nuance here is probably people who have high cholesterol. But eggs are a great source of choline, vitamins A, D, selenium. They really have a lot of nutrients in them. And fish, though, we'll keep fish on the other side of the food discussion, meaning fish are really high in omega-3 fatty acids. They are more anti-inflammatory in spectrum. Fish can contain mercury, which if you're trying to get pregnant, we really want to be careful because mercury can be neurotoxic and can damage the brain. So we usually max out at 3 servings of fish per week if you're trying to conceive. Full-fat dairy actually looks more advantageous for fertility than low-fat. There's a lot of mixed dairy studies, but what they agree upon is that likely the processing of taking, we'll say, milk into a low-fat product makes it less good for you and removes some of the benefit that dairy can have. So if you do consume dairy, we recommend you do the real deal, the full-fat version of it. And that's really a whole food-based approach. The problem is a lot of times we eat out of convenience. We grab a bar, we get takeout food, or we're unwilling to explore because it's difficult. How do you cook with lentils if you never have? And of course, there's also, being able to afford food is expensive.
And afford the time to prepare the food, I think, is a big part of it. There's a whole contingent of people online who are like, I didn't have my period, and then I started eating a lot of red meat, drinking raw milk, consuming that type of diet, and I got my period back, which is a sign that it helped my hormones.
For women specifically, we do have a major issue with underfueling. So a lot of times when women don't have a period and they're in this circumstance, they are going from underfueling to fueling. And it's not necessarily that it's the quality of the food that they're doing now. It's simply that their body feels nourished. There are some truths to be told. Healthy fats, especially ones that are coming from nuts, avocados, olive oils, cholesterol is the backbone for steroid hormones. So if we want to make progesterone, you need to have cholesterol so that we can make it. But more saturated fat in your diet is associated with higher rates of infertility. So not all fat is created equal, kind of going back to this principle. Also, when we see a lot of a dietary change, I can say a carnivore diet is not the best diet for fertility, and the data supports this. Is it better, though, than the standard American diet or one that's high in ultra-processed foods? Probably, right? So two things can be true at one time. And sometimes it's, a spectrum of going from worse to better. And, if that's how somebody thinks that they feel their optimal health, I'm not the one to argue with them. I'm here to give them data so that they can make decisions with it.
So all of these things, we have sleep, we have building muscle, and we have the foods that we eat. Are those all equally important for men? Are they important for men, but not as much?
Oh, more important for men. And we should add in some of the other variables as well, notably toxins, which impact both male and female fertility, but men even more. So let's talk about sperm for a minute. Do you know how many sperm are made a second? It's so many. 1,500 sperm a second.
That's
wild.
Arguably too many.
It's like they function so poorly. They need that much redundancy.
Yeah, there's not metaphors here. We don't need to look for the metaphors here.
But they're so sensitive. Let me tell you this. Sperm are so sensitive.
Another metaphor we might not want to look for.
So this is really important, though, because if we think about sperm, men create them, right? I didn't sit here and say we get to create eggs because they're in our body our whole life. We're born with them. So men create sperm every single second of every single day. So we'll say 90 days from the I'm going to make a sperm until there it is in the ejaculate. That means that sperm are so influenced by the environment of a man. Things like cannabis use, smoking cigarettes, alcohol, sugar, stress, being overweight, arguably impact male fertility more because they can make a bigger delta, right? There's a bigger change that can happen. If we stop using cannabis, you're going to have a new sperm count in 3 months from now. So half the DNA when it comes to getting pregnant come from the sperm. The DNA is packaged. It is, of course, going to be influenced by that male environment. And there's some causes of inflammation that we can't help. I will say the top thing that I see in my practice right now is men using cannabis, thinking that it does not impact their partner's fertility. It impacts embryo development. We see embryos stop developing when that male genome kicks in. It lowers sperm counts. It can lower motility rates. It's also independently associated with higher rates of pregnancy loss in female partners, even when the female partner doesn't use cannabis at all. Like, to me,
is that any level of cannabis use?
It looks like any level of cannabis use.
All right. I feel like a lot of people are like pausing the podcast and going to send it to their partner, their brother, or somebody that they know. Yeah.
Yeah. And when we look at, if you've used cannabis in any form, in this month or in the prior month, even for women too, we see poor IVF outcomes. So these are things that I think we live in a culture right now where I see a huge shift in alcohol. I love that, right? 10 years ago, coming on a podcast and saying you should stop drinking would be absurd. And now when I say you should stop drinking if you want to decrease your inflammation, it is well accepted. So culture has shifted some in good ways. But what I've seen is a lot of people replace that with cannabis use instead. And
we haven't fixed the root. We are not living our lives in a way that's conducive to feeling good. And so we've just added another coping mechanism on top where alcohol used to be.
Exactly. And chronic stress is a driver of hormone health, meaning when your body is constantly stressed, your stress response has a physiologic purpose. So if we think about acute stress, Liz sees a bear you want to run from the bear. So your body is meant to activate and get glucose, breaks it down again from the liver, puts it into your bloodstream so that you can use that glucose from your muscles, your heart, your lungs, and get away from the bear. But in today's world, that's not what causes us to be stressed.
Yeah.
It's emails, meetings, bad news. And instead of running and using our muscle and, using that glucose, which would have happened if there'd been a bear, we double down. We drink alcohol, we use cannabis, we stress eat, we don't get sleep, we stay up later. I hate the stress narrative because I see a lot of fertility doctors going, don't stress about being stressed. And I don't think that's helpful because—
And I have so many friends who deal with infertility, and a lot of them are public figures, and people will just be like, I can tell you're super stressed out. You just need to stress out less and then you'll get pregnant.
That is
and I'm just
not
like,
helpful.
It's infuriating.
It is unrealistic for me to tell you to live in a low stress world or to live a lower stress life. So I think about stress in a couple different ways. Number one is, yes, you should try to cut down the stress that you can, right? Saying no to things, cutting out things, getting help where you can. You should actively think about that. Number two, though, should be, I live in a stressful world and I will encounter stress today. So I need to build into my day a way to get that cortisol, that stress hormone, to decrease. And how am I going to cultivate that? Because for a lot of my extremely successful, busy women, if it's not on their calendar, they are not doing it. So when are you going to put the 20 minutes of acupuncture, meditation, the walk with your friends outside, calling a friend on the phone, mindfulness, yoga, feet in the grass, coffee on the back porch? And then number three, what I think is most important and not talked about enough, we already covered skeletal muscle is the key to fighting some of this insulin resistance. Insulin resistance is the mechanism why chronic stress can be harmful. So if you get the bad email, you leave the fertility doctor and you got crappy news. Don't stress eat, don't stress drink. Instead, try to use some muscle. And it doesn't have to be crazy, right? 10 squats in place. Go for a quick walk just down the block and back. Knowing that if I can activate that skeletal muscle, my body just freed up glucose because it thought that doctor's appointment was a bear. I need to go use some of that up. And that is an active recovery that's actually going to be helpful in building your resilience to stress.
Going back to sperm.
Yes.
Sperm counts have decreased 50% in the last 50 years.
Yes.
What do you attribute that to?
That is living in a chronic inflammatory world. If we think about today's world versus 50 years ago, it's almost uncomparable. The foods we eat, the life we live, obesity rates, chronic disease rates, the rate of change in inflammatory disorders, meaning increase in autoimmune disease, increase in chronic inflammatory disease, parallels with this drop in sperm counts. And when we look at the last 20 years, sperm counts have dropped the most of that whole time. So it really is a problem that is reflective of not just one single thing. It's not, oh, everybody's overweight, but it is the current food that the average person eats, the toxins they're exposed to, the life that we lead. What we have normalized as okay is actually harming our body and our hormones. And sperm are an easier way that we can measure that over time.
How often when you see couples in your practice, are the fertility issues due to something on the female side versus the male side?
It's 50-50.
Okay.
Yeah. So I say fertility is a team sport. And, probably a third of that time, there's dual factors involved.
Interesting. Okay. And then going back to we're going into 20s, 30s, 40s, et cetera, how does age impact sperm?
Liz, I love it. We're back to the very first question. So age does impact sperm too. Men also have a biological clock. It's just not quite the same as women. So as men get older, inside both your testes and your ovaries, you can get fibrosis. This chronic inflammation can change how they function. And that happens on both ends at some point, in addition to they just wear out. So all men will stop producing sperm and testosterone at some point. We see lower sperm counts in men who are over age 40. We see the most profound in 50 and older. And in fact, as men get older, we do see some specific issues when it comes to children. Higher rates of autism, higher rates of schizophrenia, higher rates of specific autoimmune diseases that are new onset genetic mutations, and something called imprinting disorders. Meaning they don't get just a hall pass because they're men and they're not women. And so much of the fertility conversation has always centered on women. Does this mean all men should freeze their sperm at a younger age? I think it's a good question because it's so much easier than for women. Right? You've been through the process. So freezing eggs or embryos is so involved for women, yet for men, arguably much easier. I think if a man wants to have kids one day, then it should be something he should maybe consider as he's in his 30s.
Does it exist? Like outside
Yeah.
of sperm donation, you could like, there's
Oh,
sperm,
yes.
you can like.
We do this for men who have cancer, who maybe are getting
Oh,
chemotherapy or
yeah.
undergoing other
Mhm.
treatments. I have a few men because testosterone is male birth control for all intensive purposes. So many men might experience some symptoms of low testosterone, such as weight gain, fatigue, low libido. Go see a doctor, get diagnosed with low testosterone, a real problem, and get put on testosterone replacement therapy. The problem with TRT is it talks to the brain in men and says, we have testosterone. Testosterone and sperm are made together. Therefore, it won't make sperm either. So taking testosterone is the top cause of what we call non-obstructive azoospermia, meaning having no sperm in the ejaculate from a non-obstructive cause like a vasectomy. And this is sometimes irreversible.
What other things do you want women in their 30s to be aware of when it comes to their reproductive health?
So I think in your 30s, this is where we really have to have the what I say is, what is your goal conversation, well, at least with yourself. Do you want to have kids one day?
I feel like a lot of people don't know. Like
lot of
we're
people
like,
don't.
I don't want to lose the option. It's annoying that the option is being lost as time goes on. But since I don't know, I don't want to be taking big steps in that direction either.
I agree with that. But so often I find that women aren't even taking the time to think through what their life could look like on either trajectory. And sometimes we say, well, maybe I want them, maybe I don't. Maybe if life goes XYZ, then I will. And I think that's really understandable. But let's say life does go perfectly. XYZ do happen, and you want to be able to have children. At some point in your 30s, freezing your eggs is a really smart idea because we do know that incrementally as we get older, pregnancy rates start going down. We don't see that big fertility cliff at age 35. Age 35 is when about half your eggs will be genetically normal and half your eggs will not for the average person. We've already talked about there's some individualization based on your metabolic health. We see the big fertility declines start to happen at 38 and on. So every year after age 38, we do start to see changes in your ability to get pregnant. But that doesn't mean you can't by any means. But you would want to enter into pregnancy attempts at a much more knowledgeable stage.
Okay, I have so many questions about the egg freezing thing. Like one, just straightforwardly, is there an age where you don't think it's worth it anymore?
It's really hard to say. Statistically, age 45 would be the age. Many clinics won't do it in your 40s. There's some paternalism to that because who am I to say what is worth your financial resources or not? The odds of cumulative success may be low. That may be higher than zero, which could be what you're sitting at right now. The oldest patient I've had freeze eggs and then have a child is 44.
And she had a child with her own egg.
Yeah, she was at 43 and 44. She was going through a divorce. So life took a different direction than she thought. We froze eggs. And then when her divorce was final, we got a sperm donor. And she said, I'm not waiting on motherhood for a man anymore. And we thawed those eggs from 43 and 44. And it was one of her 44-year-old eggs that got her pregnant.
And in general, if we freeze eggs and those eggs are all tested and they're like deemed good and frozen away, are the eggs you end up with as good at 40 as they would be at 30? You just end up with less of them if they've gone through that testing cycle, or are they somehow worse?
Importantly, when you're freezing eggs, we can't do full testing. We take them out of your body and we freeze them if they're the right stage of maturity. I actually know nothing about the egg's quality at that moment when it's frozen.
Okay.
It's just frozen. It just met the goal as far as being the right stage of maturity. When I thaw it and fertilize it, whenever you're ready to get pregnant, we're going to see drops. Not every egg will fertilize. Not everyone will grow into an implantation stage embryo. And then the rate of genetic normalcy will be tied to your age. So one of the hard things is that egg freezing makes a whole lot of assumptions because it's human nature to assume you're going to fall average. Yet I can sit here and tell you the definition of average means some people do better and some people do worse. So we often buffer that risk by trying to get more eggs, especially if you are older. But there's no number of eggs in a 40-year-old that would make me sit here and say, you're guaranteed to have a pregnancy. So when do you stop and how much do you do? It's a really hard question to answer. When you're younger, you're able to achieve those numbers that give us much higher probability of odds that the eggs will achieve success. The average 40-year-old, about 25% of her eggs are going to be genetically normal. The average 30-year-old will have about 65% of hers genetically normal. So Add to that the average 30-year-old will have 20 eggs and the average 40-year-old will have 8. Okay. So the math is harder to math.
Yeah.
It's not impossible math, though. I see 40-year-olds do multiple cycles. This begs the question, though, that if we could have known that information sooner, it would be easier. So a lot of the fertility journey is trying to set yourself up for success.
Do you worry that we're overselling the safety net of freezing eggs? I know a number of people where they were like, okay, I froze my eggs. Now I can go back and work and do all these things and not worry about it. And then they don't have any live births from those eggs.
Two things can be true at one time. Egg freezing is a remarkable technology that has allowed a lot of people the opportunity to have a family. However, it is by no means an insurance policy, and that narrative has harmed people. I reframe egg freezing as an investment. It is putting your money in the stock market. The ROI on that investment, you don't know yet. It depends on factors we don't know. We don't know the sperm yet. We don't know how healthy you'll be later. We don't know what will happen in the lab. We're making a lot of assumptions, just like we do when we invest our money. And I think if we educate women about what it is and what it's not, it's an opportunity. Very often I will tell patients, okay, this is how many we got. We run the math. This is how many embryos it would likely give us.
Can you share some of that math?
Yeah. When we do average math, and again, my big disclaimer, average by definition, some people do better, some people do worse. Not every egg will always survive the freeze-thaw process. It is a single cell. It has DNA, mitochondria. It's really remarkable that most of it is water and we're able to freeze it and thaw it and have it function. About 10 years ago, about 40% of your eggs survived the freeze-thaw. That was the older technology. Outcomes were bad. Current technology is significantly better. About 90% of eggs survive the freeze-thaw. This is with vitrification, a faster freeze process. So let's use the average 30-year-old who froze her eggs and she got 20 eggs. So now 18 of them have survived the freeze-thaw. Then we're going to go and fertilize them with sperm. And not every egg accepts a sperm. We usually see about 65 to 70%. So let's say our 18 went to 14. Okay. We now have 14 fertilized embryos. These have to grow to an implantation stage. This is when an embryo implants in your uterus. About half typically make it to that stage. So now we've gotten to 7. Let's say 4 out of our 7 were genetically normal. Okay. From here, a single genetically normal embryo has about a 65% chance of live birth, which is much higher than nature, but nowhere near 100. So this means you're going to want the math equation to work out where you have 2 to 3 genetically normal embryos for every child that you would like to have. Cumulative rates are good, meaning after 2 embryo transfers, not at the same time, but cumulatively, you have an 83% chance of having a baby. And after 3, it's almost 95%. So this means recurrent implantation failure, not getting pregnant after 3 genetically normal embryo transfers is quite rare, 5%. But that means you have to have 3 embryos. Okay. And I just gave an example with a 30-year-old patient falling very average who ended up with 4. So it doesn't mean it's impossible at older ages or with lower egg counts. Typically, if you're 35 and older, and you're going to need to do more than 1 cycle for most of the time.
Are there any negative impacts of doing these egg freezing cycles on your body?
I mean, short term, it's not fun. I think we have to acknowledge that. It's local injections. These are very short-acting hormones. FSH and LH, we are giving you those exact hormones to get the eggs to grow. So it's nothing crazy or synthetic. All of these eggs are growing at one time. The ovary will get larger and heavier. As estrogen levels rise, you're going to notice it. You're going to start to, we call third space the fluid. Estrogen is really important for the stability of our blood vessels. But at really high levels, it actually causes some of the water component of your blood to leak out. And this is why you might have more we call ascites, like fluid on the abdomen. And this can progress. You can get fluid on your lungs called pulmonary effusion. But then your actual blood, though, is quite dehydrated. So your blood's thicker and you do have a little bit of a higher risk of a blood clot, and it can even cause kidney damage at really high levels. That's called ovarian hyperstimulation syndrome, or OHSS. Typically happens when we have very high egg counts and estrogen levels get very high. I will say rarely happens in current modern practice to get severe. When I was first in this field, stimulation protocols were differently. The medications we had were a little bit different. And we would see women, especially the younger you were and the more eggs you have, get severely ill, hospitalized for weeks.
I have a friend who's hospitalized.
Yeah, really, really terrible. Now that is a much more rare occurrence with some of the modern protocols that we have. So for women who have a high egg count, we can use different protocol, different trigger shots so that the estrogen's not stimulated in the same way. So short term, you do have some of these risks. And then, of course, to get the eggs out of the body, as you know, it's not a super fun procedure.
It's not that bad, though. I was so nervous about it, and it was not nearly as bad. Like, it was so fast.
Okay.
And then I felt pretty much instantly better that day.
You will feel better. It's a very large needle that we attached.
I don't know if I need to talk about that.
It's a very large needle that gets attached to a vaginal ultrasound. And we're going vaginally into the ovaries. It's crazy.
I didn't know. I think I was out for a reason.
You were. There's a reason why you should get anesthesia for the process.
Do some people not?
Yes. I know. That's why I'm sitting here saying.
For the very large needle
for
of
the
their
very
vagina?
large needle in their vagina. Some people do not get anesthesia. I think that's inhumane. I'll be really transparent. You should make sure that you're at a place where you get anesthesia for your egg retrieval. I do not think we should be torturing women by putting large needles through their vagina into an organ and moving it around to get eggs out while they are awake. But there are clinics that do this, and they do it under the argument of lowering cost. Okay, not appropriate. So make sure one of the questions to ask if you're going through this is, do you have anesthesia? But I will say most of the time that's not. It's a very fast procedure. It's about 15 to 20 minutes. You'll usually feel fine afterward. It's a needle, though. It's not risk-free. Risk of complications less than 1%. Bleeding is going to be most common. But like anything, you have damage to internal structures. You may not be able to get every egg. The ovaries do move around. One of the things I see very common people ask is the fear of a long-term risk of ovarian cancer from doing IVF. And there's no studies to support there's an increased risk of ovarian cancer or breast cancer from going through the process. Even though these are high hormone levels, it's very transient. It's in one menstrual cycle. You'll go back to normal the next month. And hormone levels are so much lower than there are in a pregnancy also. So just for comparison's sake, yes, we're manipulating your physiology to get to a certain goal, but the next month you can go back to normal or we could do it again. Even doing multiple cycles, we don't see a negative outcome.
Is there an amount where that tips for you? Like, I have a girlfriend, she did 7 cycles and she feels that it made her enter perimenopause earlier.
It didn't. So when it comes to understanding this common question, we can only get the eggs outside the vault to grow. So these eggs have already been released from the vault. You were naturally going to lose them that month anyway. That's what we're trying to stimulate to grow when we do egg freezing or IVF. I cannot tap into the vault. Now there's current tech where they're trying to, and they're trying to learn how to mature immature eggs in the lab. We're trying to do IVF without having to do all the stimulation meds. But right now, there's no way to tap into the vault and get those eggs. If we could, that would really change the game for us because we'd be able to have better numbers no matter your age. But that doesn't exist right now. So we're not going to go into menopause sooner. I will say sometimes we're more aware of it because your hormones have just gone from a high to a low. The other thing I would say is that, especially when we're doing multiple cycles, if you have I'm going to assume your friend had a lower egg count, that's part of why we're going through multiple cycles. At some point, the switch goes off and your ovaries go into failure. And that's what menopause is.
But that wouldn't be sooner.
It wouldn't be sooner because you're doing this. But I will have some women who it just happens, meaning one cycle, we stimulated, got 3 eggs. The next month, her ovaries no longer will respond. Her light's off. She's now in menopause or ovarian failure. Just the switch got flipped. The process didn't cause it. We just captured that moment in time.
Almost like if you're doing 7 cycles, there's probably something happening in your body that might have kicked you into perimenopause earlier. And you're just aware of that because you've done the 7 cycles and it might kind of line up timeline-wise.
Yeah, right. Menopause is one day in time. It's when you classically defined as don't have periods for a year and in ovarian failure.
Yeah.
We use the ovarian failure term a lot in the IVF world, kind of independent of menopause, even though they can be the same thing. Perimenopause is diminished ovarian reserve. If you have a low egg count, you are in the 7 to 10 years before you will go into menopause. So very often, I think fertility doctors are doing a bad job telling patients, hey, your AMH is low. We should freeze your eggs, get embryos. We tell them that part really well. But what we don't say is, this is perimenopause. You're going to go into menopause early. We need to be thinking about that. And especially for my women who have a very low AMH, less than 0.1, how imminent is it? I don't have a magic clock to tell me, but what I tell patients at some of these very low levels is these are places where time is of the essence. And we do need to make forward progress because that menopause or ovarian failure line is imminently approaching.
Is there anything that you do differently in your clinic to either get better outcomes from egg freezing that people could mimic in their own lives or to recover better from it?
Oh, that's a really good question. When it comes to outcomes, we talk about egg quality. From a protocol standpoint, the protocol is the combination of medications that we use in egg freezing or IVF to try to get multiple eggs to grow. So your body doesn't want to have 10 eggs grow at one time, which doesn't want to have 10 babies at once. So this really simplistic idea of me sitting here saying, I'm going to get all your eggs to grow that are outside the vault is a lot easier said than done. So the combination of medications we do to override the normal brain-ovary communication, sometimes we can manipulate those to get better outcomes. So absolutely, if you've ever done a cycle in the past, never do another cycle without having your doctor look at those results. If you're getting another opinion, you want to make sure they have your records. We want to personalize second cycles. Often there's little tweaks we can make to try to get more mature eggs. Say, a different size, a different medication, little tweaks. But a lot of the egg outcome is truly about egg quality. And that's a lot of what we're talking about here. Controlling inflammation for yourself. Eggs are inside your body your whole life. That sometimes makes people feel like, well, I've already screwed that pooch. But we know that the 60 days prior to ovulation is when the egg is the most sensitive. So to me, that says, okay, that means right now, decisions you make impact. Alcohol in the month of IVF cycle results in lower eggs retrieved. Okay. So we shouldn't be saying, just live your normal life.
Would you say 60 days is the number we should be looking at on the male and female side before getting pregnant, and also for eggs to really buckle down and get serious?
We usually say 90 days since that's what we know is that sperm timeline, right? Yeah. And it's a little bit, 30 extra days isn't going to hurt. It helps improve nutritional stores.
And also, I want the men to do more work.
Then 60 days for women, 90 days for men. Okay, they got to get started, learn how to cook all your food, remove everything toxic from the home, change their behavior first.
Yeah. Although it's interesting. So the big thing that Zach didn't do when we were doing our embryo freezing was sauna and heat. And then have you seen the Brian Johnson stuff recently?
No.
I think it's a pretty well-known thing that heat impacts sperm quality. Although I think you said this, and I thought this was really interesting, that cycling created enough heat.
Yes. My professional cycling quality have terrible sperm.
I think that's we should talk about that more. It's not just get in a hot tub, get in a sauna. It's things that create heat for your balls, essentially, in general.
3 times a month of increased heat is enough to see a detriment to sperm parameters. So even if we're just I only get in the sauna once a week or the hot tub or go in this 3 times a month.
Well, and I do think it's thinking about am I cycling? Am I doing other stuff where my balls are getting hot for a sustained period of time?
I mean, it's true. I mean, laptop and lap is another one, especially some of those laptops get really hot. And I've had some patients, some men, I don't know why, they drive with their phone under their, in between their legs. They put their phone there.
Okay.
Let's not do that.
Okay. But okay, so Brian Johnson tested sauna's impact on his sperm as an N of 1, very much N of 1. But he basically found that it decimated them, terrible. But then he put an ice pack on his balls and did the sauna.
Because that sounds fun.
And he found that all of his sperm quality, quantity, all that skyrocketed way higher than baseline. So the sauna seemed to be not good if you kept your balls at a reasonable temperature. What do you think about that?
This is a great question, Liz. The testes should be 4 degrees cooler than the rest of your body. So it would make sense that keeping them at a lower body temperature is helpful. Sauna independently has some benefits, right? If somebody's getting in the sauna, trying to take care of their overall health, decreasing inflammation, that can be helpful too. Probably there's better ways to get there than just ice pack on your testes while in the sauna. Probably avoidance of sauna in general and trying to keep your testes at a cooler temperature while doing other good anti-inflammatory practices is going to be the best thing for the average man. But it's interesting data. I always say for my patients, sauna is a great example where we don't see any negative impact on women trying to get pregnant. So you shouldn't do it once you're pregnant, but in the trying to conceive, that's your time to go to the sauna and he's not allowed in.
I know. That's what I liked about it. And then the Brian Johnson thing, I was it's kind of annoying that
now he's going to try to come in with his sperm pack.
Yeah. Okay. So let's say it's 90 days for men, 60 days for women. In general, we're doing all these anti-inflammatory things. We're sleeping, we're eating well, whatever. What do we want to add in that 90-day period for men, 60-day period for women to have the best outcome, whether we're trying to get pregnant or we are freezing eggs or embryos?
We could talk about adding in some supplements that can be advantageous. And of course, we have to give the disclaimer that there's no perfect supplement. They're not regulated. What I usually tell people is trying to choose things that are very simple and pure, meaning I don't love things that have lots of added ingredients. We often see herbs added in with supplements. And when we see a lot of herbal preparations added in, they are often to try to get to a desired effect because they modulate hormones. So examples, maca, vitex, which is chasteberry, these ashwagandha, these are often added into some supplements. And it's not that they're bad for the regular you, but when you're trying to get pregnant, we really want to think about optimal brain-ovary communication. We really want to make sure we're being very mindful of some of the impact that can have on hormonal signaling. For women, we'll say a multivitamin, a prenatal vitamin that has folic acid. So we want to have at least 400 micrograms of folic acid, omega-3 fatty acids, vitamin D, coenzyme Q10. That is my combo for women that I would say if you have the availability to take those and you want to get pregnant in the next few months, that's the perfect supplement stack for the average person. Now, depending on if you have PCOS or endo or low reserve, there's different nuance for certain things that can be advantageous. We find CoQ10 to be helpful in men as well. So that's one that everybody gets, an antioxidant, helps improve mitochondrial function. The dose is a little different, 200 milligrams for men and 600 for women. So a little bit higher in the egg quality studies that have been done. And then men can have some added benefit. So things like vitamin C, vitamin E, L-arginine, L-carnitine. These are some that you'll often see in a men's multivitamin or sperm health vitamin, or that we can add on independently that can be helpful in addition to zinc, which is really important for sperm production.
If somebody has unexplained infertility in their 20s and 30s, you have reason to believe that it's not necessarily just because of their age, how would you approach that differently than another doctor might?
Unexplained infertility means that we did fertility testing, the standard evaluation, and everything was normal. This means you ovulate monthly, you have a normal uterus and tubes, your partner's semen analysis is normal. Those things all get the normal check, check, check. You've been trying to get pregnant for a year, and you get this magic diagnosis of unexplained infertility. I'll always say this is just undiagnosed. There's some reason why somebody in their 20s and 30s is not getting pregnant. It's not just unexplained. The problem is these things are hard to diagnose. So it's not that your doctor is maybe not trying, it's that there may not be a perfect test to diagnose it. These are chronic inflammatory disorders unless proven otherwise. Endometriosis, adenomyosis, insulin resistance, chronic inflammation. There is something happening that is contributing likely to your inflammatory state. Prove me wrong. That is what I tell patients. So we tend to go a little bit more down the investigation of checking for insulin resistance and fasting insulin levels, checking a high sensitivity CRP, doing a more extended autoimmune panel. This is not the medical recommendation, but to me, when I'm sitting across from somebody, I say, your unexplained infertility is a red flag waving at me. So how are we going to try to figure out what's going on? And I'm casting a bigger net to try to see what's going on. And I'm asking you to control the other lifestyle factors that are contributing to inflammation as well, because getting to zero inflammation is not the goal. That's unrealistic. We're trying to not add to that bucket. And a lot of times when we find things like endometriosis or an autoimmune disease, we're going to have higher levels of baseline inflammation anyway. So these lifestyle factors matter even more. So many different things that it can be advantageous. And I think this narrative gets simplified to patients. They hear, I have unexplained infertility, so just do IVF. Well, for IVF, I can take your eggs out of your body. I can see how eggs and sperm work together in the lab. I get more eggs, so I'm working with a higher number. Embryos are so sensitive to inflammation in those early embryo stages. So when it's going from day one of being fertilized to that implantation stage, in the body, that occurs in the fallopian tubes. So if you have a chronic inflammatory disorder, your embryo is constantly exposed to that inflammation, and that's really harmful for embryo growth. There's no inflammation in the IVF lab. I'm allowing that embryo to grow in a less challenged environment.
If somebody's listening to this podcast and they are kind of doing all the right stuff,
Yeah.
they're eating really well, they're working out, are there reasons that you commonly see in your practice that unexplained infertility is often due to?
Say two top ones. One is that your partner's not doing all those things. Okay. Can't say how often I see the female partner doing everything she can and the male partner doing whatever he wants. Okay. And that's true. So that's not cool. We want to change that. The top cause, I would say, of the everything is normal in somebody who is already mitigating all the inflammatory factors they can is going to be endometriosis. Endometriosis is really a damaging disease because over time, it goes from being just inflammation being the problem to scar can develop. We can have huge destruction of pelvic anatomy. It's also number one symptom is pain. And that makes it extra tough because women's pain is often dismissed. We get a lot of other symptoms as well. So common ones that I see can be GI distress. So weird GI symptoms is always, I'm thinking endometriosis. Bladder symptoms as well. Pain with intercourse, specifically in deep penetration, because some of those implants are getting stimulated or being disturbed. Those things all point to endometriosis. But it's only a surgical diagnosis in its truest form. Meaning the only way to really know you don't have it is to go and do surgery. Sometimes we can diagnose it on ultrasound or MRI, so I don't want to act like we never can, but having a normal ultrasound doesn't mean you don't have it. When it comes to getting pregnant, doing excision and taking out the endometriosis improves pregnancy rates because it decreases inflammation for about 6 months. And then inflammation markers are going to come back. It's a really tough disease and it's underdiagnosed extensively.
So when you're working with these patients, you do the excision surgery and then you're like 6 months, let's go.
That's usually the generic advice if they're young. I will say some big mistakes I see is not having full fertility testing before you enter that 6 months, because do you know how frustrating it is to then find out sperm counts are near zero and you just went through all these hoops and maybe sperm counts were such that you needed IVF anyway. IVF can be helpful because we are growing the embryos in a different environment. So many women with stage 3 and 4 endo end up needing IVF because it is one of the ways we really can change the environment of their body and improve their odds of success.
So straightforwardly, if somebody's listening and they're like, I have unexplained infertility, I have these really painful periods, this could be me, what's their next step?
Let's go and see a fertility doctor, get testing done, and then let's think about what's the best next step for your situation. Maybe it's excision surgery. That definitely can help with pain. So if pain really is impacting your quality of life, twofold reason why that can be advantageous. Sometimes fertility is our sole goal at the moment, and it might be a smarter game plan to shift towards IVF without having excision surgeries.
Is IUI ever worth it? I feel like it's bullshit.
IUI is not bullshit. It's apples and oranges. Let's use an average patient, average 30-year-old. Your odds of getting pregnant, if you don't have infertility, you're just trying to get pregnant, about 20% per month, okay? 72% of people get pregnant in the first 6 months. About 13% more will get pregnant in the next 6 months. If you fall into that group that didn't get pregnant that year, you now have a 4 to 5% chance of getting pregnant by trying naturally. So not zero, not really high, doesn't feel super great.
Mm-hmm.
IUI doubles that odds.
Why would you ever do IUI versus just skip to IVF?
For unexplained infertility, if we didn't live in this country, we probably wouldn't. But because we don't have healthcare that covers IVF, it's so cost prohibitive for most people.
So IUI is much cheaper.
IUI is much cheaper. It's about, 1/15 the cost of IVF. So if you look at it, hey, it has a lower success rate, let's say 65% IVF, we'll say 10% IUI, 5% naturally. For many people, it feels like, well, I can't do this. I got to save up for this. Maybe I can try this and see if I can get a win at a lower price point. We shouldn't do it over and over again because we're just wasting your money. And I do see this and it breaks my heart where people will try IUI for a year and then before they're moving on to IVF, and they've spent more money than they would have if they'd just done IVF.
Yeah.
If IUI is going to work, we see it work most of the time in the first 3 to 4 months.
Let's talk 40s. I have either been working on my career and then I'm like, oh, I want a kid, or I couldn't decide. And then I'm like, I want a kid, or I meet a partner finally and I want a kid. Is it too late for me?
It's not too late. It might be harder though. You might have signed up to run a marathon versus an easier race. If you are 40 and older and you want to have a child, let's not wait any amount of time before we go get testing done. And definitely improving your metabolic health the way that we can, also very important. And because in general, although not always, older women tend to have older partners, we also want to say that sperm health is even more important in that demographic.
What are the additional risks to the mom and to the baby in your 40s?
It's a good question. Most of them are going to be strongly correlated with your own health, right? Again, people get more metabolically unhealthy as they get older. Therefore, the risk of gestational diabetes, preeclampsia, or high blood pressure of pregnancy, those things statistically go up.
Because of the metabolic health, though, are you saying in absence of the metabolic health issues, those wouldn't go up?
And they still go up, but not to the same degree.
Okay.
Right? So we can mitigate some of those risks by being healthier, but not all of them. Pregnancy is hard on your body. It's not health neutral. Being pregnant changes your entire vascular system. It changes how your blood clots, changes everything about you. Women who are 45 and older who are actively undergoing fertility treatments typically have to undergo a little bit more testing. Usually that means preventive care, pap smears, mammograms are up to date. But we generally are looking at heart health a little bit more in women who are 45 and older, making sure they're not at higher risk for a complication.
And does that math change at all if you're using embryos or eggs that you froze earlier in your life? How much is it about the carrier and how much is it about the actual egg itself?
So a lot of those pregnancy risks that I just reviewed are going to be the same regardless, although your odds of success, live birth, and improved fetal outcome are going to be higher if they are eggs, embryos frozen from a younger age. Or statistically, they're higher likelihood of having a miscarriage or having a genetically abnormal child. That sounds like a really scary thing to say out loud, but to clarify, most pregnancies in women who are older still do fine. It just means you now qualify for more testing, earlier screening, and that does become important, especially when it comes to, insurance and coverage and care.
Is there anything that we can do to lower the risk of a miscarriage regardless of age?
Yeah, that's a great question. Yeah, your partner can stop smoking cannabis. We can look at sperm health a lot more since a lot of the risk does come from sperm in addition. When it comes to us getting older, chronic inflammation across the board is associated with having miscarriage in addition to insulin resistance. So I would say, yeah, really thinking about if we get older and we have some inherent risk that we can't control, then acknowledgement of the choices that we can control, that's even more important.
How do GLP-1s factor into the fertility conversation for you?
Okay, I love GLP-1. So a disclaimer, because I've just seen such lovely results in patients, but there's limited studies, so we're going to acknowledge that. For GLP-1 specifically, the medical recommendation is to be off of them for 2 months before you get pregnant. So if you are on a GLP-1, you are not trying to get pregnant by medical definition, at least not under a doctor's supervision. That doesn't mean I don't have patients who are on them, who are taking a break from active fertility treatments, trying to change their metabolic and cellular health. I'll say for patients with any autoimmune disease, PCOS, endometriosis, I've seen dramatically different outcomes in IVF cycles after being on or off a GLP-1, even without profound weight loss. It's definitely something that I am now considering in that unexplained group. Even we're doing IVF, we're not seeing what we want. Having a discussion is this something we should take a pause for a moment? Should we try to change our metabolic health before we try this again? And sometimes that's one tool in the toolbox.
Would that carry over to egg freezing for you?
So you're not actively looking to get pregnant. You can actually be on GLP-1s a little bit longer. We stop them for 2 weeks for anesthesia risk. So usually you would stop those when you start your stimulation meds. So if you were freezing eggs or embryos or even going through IVF but not doing a transfer quite yet, which is a lot of my patients, we'll let them be on GLP-1s right up until when we're starting the stimulation. But yes, if you have known inflammatory disease or suspicion or overweight, look, if you're spending money, time, physical energy, your resources to freeze your eggs or your embryos for fertility purposes, I think you deserve to be in the place to make the decisions that might control that outcome and at least say, could this give me a better goal?
Okay, I have a hodgepodge of little things. Does this impact fertility? One I know does because I read it in your book, but I never heard it before. Mucinex?
Oh, it's so interesting, right? Okay, small study, but let's just think about what Mucinex is. It's an expectorant. It's guaifenesin. Frequently, we use it when we get sick or we get a chest cold. So how it works is it helps pull water into our secretions so that you can cough them up. So the thought here is that could some women maybe have hostile cervical mucus, for lack of a better word, meaning your cervical mucus doesn't get that sticky, stretchy enough so that the sperm can swim through it. And could Mucinex be helpful? It was a very small study done without a control group, but it did look like it improved pregnancy rates in that study. I would say this, if you are somebody who says, I don't consistently see that sticky, stretchy, egg white cervical mucus, I think it's worth a try to see if it can help.
I thought that was fascinating. How big of a role do you think increased microplastics and nanoplastics in our environment is playing in that increasing infertility rate?
We'll just say the ovary, for example. Microplastics can cause fibrosis inside the ovary. So I think more than we're really aware of. Yet you can't control everything. This is where small changes, using dryer balls instead of dryer sheets, taking food out of the to-go container if you do order it, cooking at home, not eating processed foods, one of the ways where those behaviors add up to make a big impact.
What about personal care products, because
Mhm.
I think this is a hot topic of debate. A lot of chemists online say that your skin is a barrier. This stuff is not getting through your skin in a way that creates any sort of profound, like, systemic impact. And then I hear a lot of people, particularly in the hormone areas, say, no, this is actually having a big impact on our hormones.
Yeah, especially fragrance. Your skin is really permeable. It is, yes, a certain barrier, but when it comes to a lot of these products, they can be what we call endocrine disrupting chemicals. They directly are known to impact your endocrine system. This can go everywhere from puberty onset, production of estrogen, progesterone, ovulation, getting pregnant, and if you're pregnant, even can impact your fetus's endocrine system. So I think this is a big deal and not something to just peach posh over. So if it's something that you use every day, those are the things we want to start by paying the most attention to. So your shampoos, your lotions, things that are going over large portions of you that you're frequently exposed to. You can look at the environmental working group at Skin Deep. You can look at your exact product and see if it has chemicals in it that can be harmful, and then look to try to find a good replacement. The things that we're rarely exposed to, your date night perfume, your once in a while this or that, I'm much less concerned about those than I am the things that you use every single day.
You said particularly fragrances.
Yeah, fragrance can be a part of in the phthalate family, which are definitely known endocrine disruptors and have definitely distinct impact on how we ovulate and our ability to get pregnant. So unscented is one of those greenwashing words where something may say unscented. You actually want it to say fragrance free is what you're looking for.
Oh, interesting. Unscented, like a scent of unscented.
Right.
Okay, cool. Super awesome.
Don't we love that?
Marijuana, we decided very bad. Vaping.
Bad. We'll say all nicotine is bad. Vaping also has a lot of heavy metals in it, is definitely associated with negative sperm parameters without a doubt. Nicotine use can be extremely impactful for eggs, causes ovulation dysfunction, and is one of the causes of early menopause.
Yeah, I learned that from you too, and that was crazy to me.
Yeah.
Is there anything else that leads to early menopause?
Any autoimmune disease does. So if you get diagnosed with Hashimoto's, with celiac, any autoimmune disease increases the odds that you'll go into menopause earlier. I think a lot of young women might carry an autoimmune diagnosis and not know that. So if your mom has Hashimoto's, your aunt has rheumatoid arthritis, that might be something where you want to get a fertility evaluation or check that ovarian reserve earlier. Endometriosis is associated with a low ovarian reserve, that chronic inflammation, getting chemotherapy. So this is why we really push fertility evaluation, considering egg or embryo freezing. If you get a cancer diagnosis and you're not sure that you're ready to give up your fertility, even if you never end up needing or using those eggs or embryos, patients report having happier life scores because they have that door of opportunity open.
Caffeine.
High doses of caffeine are associated with potentially infertility or pregnancy loss. That's 200 milligrams a day. A standard cup of coffee you brew at home will be less than that. A standard cup of coffee from Starbucks will be more than that. A single espresso shot from Starbucks has 75 milligrams. So like a latte that's a grande has 2 of those is 150. That's going to be your safe zone. But how Starbucks, for example, brews coffee, a single cup, even the small size, is going to have more than 300 milligrams in it. Wild.
That would make me have a panic attack
Same.
instantly.
Same.
Antidepressants.
Depression itself has a negative impact on fertility for both men and women, meaning being depressed, and especially untreated depression, is going to be associated with infertility. And antidepressants are not associated with harm in your fertility. And I have so many patients on them, and I would rather you have treated depression. You will have better outcomes than untreated depression. In the same breath, if you are really stable, you are at a place where you want to try to come off an antidepressant, you'll always hear us try to pull you off medications before pregnancy if you don't need them, just to unknown fetal risks. But many people are on antidepressants. The nuance is which one you're on, making sure it's pregnancy safe, and getting on that one and getting stable on it before you conceive.
Are there any prescription medications that are associated with fertility risks that we're not talking about that connection?
So some of the medications that men might use for hair loss, like the finasteride and some of those that we see for male pattern balding, those can be associated with lower sperm counts that we're not always talking about.
Wait, that's so interesting, because one of the top questions that I hear and like I've seen on Reddit is, if my partner is bald, does that mean that they're likely to be dealing with infertility issues? And it's interesting if the baldness is itself not correlative, but the treatment for it.
Not the baldness, but sometimes treatment for it. So
interesting.
I'll say just embrace the bald, shave the head and go for it.
Yeah.
Versus trying to be on treatment for it.
And too much or too little ejaculation?
Oh, good question. Too little is going to be more harmful. So because sperm are made every second of every day, if they just back up, if you're abstaining for longer intervals, you're just going to have a lot of dead guys. So abstaining for 4 days or longer is associated with worse sperm parameters. So more frequent ejaculation is going to be advantageous.
Okay, so the men who made it through the rest of this, where we assigned them a lot of labor and told them that a lot of
now
more
they get to
of this is
ejaculate every day.
now they get to ejaculate every day. So there's your reward. Is there anything else that you think is really missing from this fertility conversation that you want to make sure people come away with?
I think fertility is so nuanced, and I think it's really hard to hear everything that everybody's saying and to try to make decisions for yourself. As somebody who went through infertility and went through pregnancy loss, I know how heartbreaking it is. And the one thing that was the worst for me personally was that lack of control. So I think there's this delicate balance that you spoke to earlier. Like, we can't control everything, but knowledge we control. So you're listening to this episode and you learned. So be proud of yourself for that. How we advocate and show up for yourself. I think one of the biggest things is don't do what I did when I had infertility. I didn't tell anybody. I didn't tell anybody I was pregnant. I didn't know how to tell people when I had pregnancy loss. I doubled down on feeling alone and isolated, watching my friends and family achieve these life stages I wanted to be at because I didn't know how to open up. But yet we know that community and social support really can help counter stress. So I would say, please give the people in your world who care about you the opportunity to show up. And the last thing I'll add is, if somebody you love is going through infertility or has a pregnancy loss or going through something like this, really try to show up in a tangible way. So instead of just, Liz, let me know what I can do. Well, that puts the burden on you to tell me what to do. Try to say, I sent you a gift card for dinner, or I'm going to this place for dinner. Can I order, you something? Like, I'm going to pick your kids up from school if they have kids, or I know your husband's out of town. Can I go with you to that doctor appointment and be your person? Like, those things matter. Your presence matters. And so try to be present for the people in your life.
I have 2 questions that I ask everybody.
Okay.
One, and this can be fertility related or not. What is one thing that's changed your life?
Honestly, one thing that's changed my life is the way that I eat. And I know that sounds like really, simple in this context of this episode, but I grew up very traditional American and we served steak and potatoes at our wedding. And in 2008, I stopped eating meat. And it was, to me, night and day different. I always just had stomach problems, was diagnosed with anxiety because of it, and really fit the bill for that dismissed patient. And I felt better. And I didn't know if it was the meat or what it was. Many years later, went through my own infertility. 10 years after that, found out I have celiac disease. My doctors now think a lot of the meat was that you're replacing it with those better vegetable-based options, and that when you don't eat meat, you cut out gluten, like you don't have a ham. Now there's some meat substitutes, so it's a little bit different. But especially then, I cut down the amount of gluten I was having and I felt night and day difference. And like we were talking about earlier, once you know what your optimal is, like you don't ever want to go back. And I hear that from my patients too every day, that once they've changed how they eat or they sleep more, or they've stopped drinking alcohol, they can't imagine going back to the time where they were doing that because they almost didn't know how good they could feel. They didn't realize how bad they were. So don't be afraid to be your own N of one experiment. Like that has changed my life the most.
Well, that's a perfect segue into our last question. We always ask for one homework assignment, something that people can do the second they turn off this podcast that can begin to change their relationship with whatever we're talking about. Knowing that fertility is not just about having babies, but it's really about your entire life, your entire health. Can you give us one homework assignment to begin to optimize our fertility?
I love it. Treat yourself like your own N of one. And let's start with sleep, which we already talked about. I want everybody to take a real actionable approach to how you sleep and say, how do we make this better? So are you getting 7 hours? Is the room dark? Can you get a sleep mask? Do you need a sound machine? Can it be cooler? Where do you charge your phone? Put it further away. And it does no good if your partner's jumping in bed 3 hours later because they're up later. If you're trying to get pregnant, if you're going through perimenopause or menopause, you want to have the optimal hormonal function that you can. Sleep, I would say if you sleep in the bed with somebody, you guys have to be on the same sleep pattern.
Do you sleep divorce with your partner?
No, but I threatened him. And so now he comes to bed earlier, things, you know what I mean?
Yeah.
Because we have really different.
And I don't think it's a bad option. I think we talk about sleep divorce, like something must be wrong with your relationship.
No.
But I know a lot of couples who are like, we will be in a better relationship when we're
If you
awake
get better
if
sleep.
we are separate when we are sleeping.
Sure.
Can you tell us a little bit in your own words about your wonderful book, The Fertility Formula?
This is the book I wish I had when I had my own infertility. It's what I found myself wanting to search for, the questions that I had that traditional medical training didn't answer for me, and what I wish all of my patients would have well before they come into my office. In the perfect world, you would get this book in your 20s, learn about your fertility, and then be able to reference it later on if you're trying to get pregnant or have infertility. But there's really something for everybody at all these different hormone stages. So your 20s, 30s, 40s, whether you're just trying to optimize your hormones, wanting to get pregnant now or want to get pregnant in the future, it's going to give you that roadmap for how you can have the best outcome you can, be the best advocate for your own health, and really make those active decisions.
It's really like an all-in-one guide to fertility. And again, I think it's important for men. I think it's important for women. I think it's important whether or not you're looking at having a child in your immediate future, freezing your eggs, whatever. There's something in here for everybody. And I just want to thank you for writing it. And thank you for sharing all of this information with us today.
Oh, thank you so much for having me.
That is all for this episode of the Liz Moody podcast. If you enjoyed this episode, I would so appreciate if you would share it with somebody that you think would love it too. It is my goal to get as much life-changing information out to as many people as possible. And you sharing episodes with people is 100% the thing that makes that happen. I would also love to hear from you in the comments, any thoughts or questions or opinions that you have on this episode. Make sure that you're subscribed to the podcast on Spotify, on Apple Podcasts, on YouTube, wherever you like to listen. You can find every single discount code that you heard in this episode and tons more at lizmoody.com/codes. It is the best way to save money on amazing vetted products. Truly, our brand partners make the best products in the world. That is why they're our beloved brand partners. And it's the best way to support the show and keep it completely free for you. And we so appreciate it. Okay, I love you. And I will see you on the next episode of the Liz Moody podcast. Oh, just one more thing. It's the legal language. This podcast is presented solely for educational and entertainment purposes. It is not intended as a substitute for the advice of a physician, a psychotherapist, or any other qualified professional.